Assessment of head injury. Early detection of increased intracranial pressure is critical. Well, why? Because if the pressure inside the skull is greater than the average blood pressure, then blood flow to the brain is going to stop. And a decreased cerebral perfusion is going to result in ischemia, distortion, and in shifts of brain tissue. Also, increasing ICP may cause partial or complete herniation. A brain herniation leads to brain death. It forces and crushes the brain downward into the spinal canal and can't be repaired, potentially lethal. Okay, I get it. Then what is the best indicator of a patient's condition? The level of consciousness. We've already learned about the Glasgow scale. The APPEW system can also be a measure for level of consciousness. A is alertness, V, verbal, P, painful, and U, unresponsive. In our assessment, we're also looking for restlessness and irritability. How does the body respond to increasing ICP? By raising blood pressure. And what does that do to ICP itself? It moves blood into the brain, again, rising intracranial pressure. The heart rate falls in response to rising blood pressure. Now, keep in mind that with autoregulation, the brain can change the diameter of the blood vessels automatically to maintain cerebral blood flow with changes in systemic blood pressure. The brain can effectively autoregulate if systolic blood pressure is from 60 to 160 millimeter mercury, and if ICP is less than 40. I'll give you the normals in a moment. However, an isolated head injury does not cause hypotension or tachycardia. Again, autoregulation of the brain is to change the diameter of the blood vessels. It is ICP itself that can lead to a raising blood pressure and a decreased heart rate. If the brain vessels dilate, there is going to be more perfusion, right? So if the opposite occurs, hypotension and or tachycardia, look at the rest of the body. Is there signs and symptoms of blood loss? Remember, shock does have a decreased blood pressure and an increased pulse. Not head injury. Head injury will have increased blood pressure and decreased heart rate. So once again, if a patient with a head injury has hypotension and tachycardia, there are other injuries present. It is important to understand the dynamics of intracranial pressure. Intracranial pressure is the pressure exerted in the cranium by its contents. It's measured with monitors in the ventricles, brain parenchyma, and or subarachnoid spaces. The skull is filled with brain tissue, cerebral spinal fluid, and blood. Brain tissue makes up 80%, CSF 8%, and blood 12%. Well, what is the Monro-Kelly hypothesis? This hypothesis states that if one expands, others must decrease, or it will lead to increased pressures. Normal ICP is 5 to 10 or 15 millimeter mercury, measured at 30 degrees. Pressures of more than 15 can seriously impair cerebral perfusion and need to be treated, as sustained increased ICP leads to ischemia and tissue damage. Let's look at causes of increased intracranial pressure. This can include lesions, hydrocephalus, abnormal CSF production or circulation, cerebral edema, which is most frequently the case, encephalitis, a swelling of brain tissue, and hemorrhage. Now keep in mind, both blood and cerebral spinal fluid equally contribute to normal intracranial pressure, but vascular factors or changes in vascular factors can account for twice the amount of increase in ICP than cerebral spinal fluid. Now let's talk about perfusion to the brain. Cerebral perfusion pressure is the amount of blood flow from the systemic circulation that is required to provide oxygen and glucose to the brain for metabolism. Remember, the brain needs constant oxygen and glucose, and an interruption of blood flow is going to lead to ischemia and disrupted brain metabolism. Cerebral perfusion pressure equals the mean arterial pressure, or MAP, minus the intracranial pressure, or ICP. Well, what is the MAP? MAP is the average blood pressure in the vessels all the time. It is the systolic blood pressure plus twice the diastolic blood pressure divided by 3. Normal cerebral perfusion pressure is 70 to 100 millimeter mercury. A cerebral perfusion pressure of less than 50 millimeter mercury results in Cushing's response. Cushing's response includes an increased systolic blood pressure, a widened pulse pressure, and a decreased pulse. Altered breathing pattern usually also accompanies a Cushing's triad. Cushing's triad or response is a late sign. And what was the compensatory mechanisms for increased intracranial pressure? Autoregulation. This is where the brain changes the diameter of its blood vessels automatically to maintain cerebral blood flow with changes in systemic blood pressure. And remember that the brain can effectively autoregulate as long as the systolic blood pressure is 60 to 160 and ICP is less than 40 millimeter mercury. There are other factors that can affect intracranial pressure. Okay, this is important. Write it down. An increase in CO2 and hydrogen ion concentrations can lead to potent vasodilation, and this is going to increase cerebral blood flow. A decrease in CO2 is the opposite, vasoconstriction. Oh, I forgot to say that if blood pressure or ICP increases above those parameters for autoregulation, the body is going to lose the ability to control it, and increased intracranial pressure is going to worsen. Manifestations of increased intracranial pressure are going to be related to the location and cause of the increased pressure. Higher level of function and cognition is going to be affected first. Then, as pressure increases in the midbrain and deeper, more primitive functions are going to be affected. Early signs are altered mental status, secondary to hypoxia. So we can see disorientation. A person is going to first be disoriented to time, then to place, then to person. Other altered mental status changes includes confusion, restlessness, behavior or personality changes, lethargy, unarousable, eventually leading to coma. What other manifestations of increased ICP? Well, headache, which tends to be worse on rising and with position changes. Speech changes, or vision changes, such as diplopia, blurred vision, papilledema, which means optic disc edema, and sluggish unequal pupils, leading to dilated fixed pupils. There can be contralateral hemiparesis, leading to hemiplegia, and decorticate and decerebral posturing. Hyperthermia can be dramatic. There is an impaired hypothalamus, thus failed compensation. Altered respirations from an impaired hypothalamic function and loss of response to carbon dioxide. So respirations can be decreased. Vomiting, which is often projectile, from compression of the brainstem directly stimulating the vomiting center. Seizures, and Cushing's response. Remember, hypertension with wide pulse pressure and low heart rate. Your book makes a distinction between cerebral edema and brain and cerebral swelling. Please look into that. Cerebral edema refers to increased fluid surrounding the tissues in the extracellular fluid or the cells. And brain or cerebral swelling is from increased brain tissue from increased blood volume. So if you have a patient with rising intracranial pressure after a head injury, you might see hyperthermia, bradypnea, hypertension, bradycardia, and etc. The little box on your slide is a reminder or a mnemonic for some of the manifestations occurring with ICP.